Hey everybody, good evening and welcome to our presentation. Thanks for joining us tonight. The presentation is the stages, symptoms, and treatment options of menopause. Hot flashes, weight gain, and irritability, oh my. Tonight we welcome two presenters from Columbia University Irving Medical Center, Dr. Mary Rosser and Lauren Golfer. And before I read you their bios, for those of you not familiar with the Kensington, I'd just like to say a few words about us. So we are located in White Plains. We are the Kensington Assisted Living Residents, and we are committed to providing excellent care for those who have cognitive and or physical need. If you're searching for assisted living for a senior, please feel free to reach out to us. Our number is 914-390-0080. Now I'd like to introduce our speakers, and I'm going to read you their bios. Mary Rosser, MD, PhD, NCMP, is the Director of Integrated Women's Health and the Richard U. and Ellen J. Levine Assistant Professor of Women's Health in Obstetrics and Gynecology at Columbia University Irving Medical Center. She has been a practicing obstetrician gynecologist for more than 20 years. Dr. Rosser received her undergraduate degree at Emory University and a PhD in endocrinology at the Medical College of Georgia. She attended Wake Forest University School of Medicine and completed her residency at Emory University. She is also a NAMS certified menopause practitioner, able to provide high-quality care for patients at menopause and beyond. Welcome, Dr. Rosser. Lauren Golfer, NP, is a board-certified women's health nurse practitioner with a passion for caring for the whole patient. Her approach is informed by a belief in a strong patient-provider relationship. Her focus includes gynecological disease management, family planning, trauma, and LGBTQ care. Lauren began her career in marketing and grant writing and received a degree from the University of Maryland as part of the College Park Scholars Program. She soon realized she wanted to work directly with patients at the ground level and went back to school to study nursing at New York University. Lauren spent several years working in the OBGYN area before entering the Women's Health Nurse Practitioner program at SUNY Downstate Medical Center. Here she was a recipient of the Dean's Award for Outstanding Contribution to the Downstate community, as well as graduate speaker at Convocation. Welcome, Lauren. Ladies, I'm going to ask you both to come on screen, and we'll start our presentation.
Hello, everyone.
Great.
Hi, everybody. Thank you so much for having us here, Brenda.
I'm going away, and it's all yours.
Thank you. Hi, everybody. Lauren and I are absolutely thrilled to be here, and I'm sorry that we cannot see you in person or on the Zoom, so maybe sometime in the future. But again, thank you for attending tonight, and I really appreciate Brenda and Gina for inviting us from the Kensington. As Brenda said, Lauren and I work together at Columbia. We mostly see patients in our Midtown offices, and we love seeing women in perimenopause, menopause, and beyond. We actually both are North American Menopause Society certified menopause practitioners, and that is a mouthful. The North American Menopause Society, or we call it NAMS, is the organization that sets the guidelines in the US for menopause care. And, you know, some people might have laughed at this before, but what's very significant is we're talking about it. My mother's generation doesn't talk about it, never did talk about it. And it's really important that we raise the awareness, because I think it's a huge gap in women's health care. And Lauren and I set out every day to educate and empower women to take an active role in their health care. And as we're all getting older in this society, it's really important that we feel comfortable in our own skin as we go through this important transition in life. So what's going to happen? First of all, I can't take the credit, nor Lauren, for the title. Brenda came up with it, and it's just really fabulous. We will review the stages, symptoms, and treatments of menopause. We've also told Brenda that she can share our slides, and if you have any questions, you can contact us. So we will start, and I will do the first part, and Lauren will pick up the second part, and we would love to leave room here for questions, and so we look forward to it. Thank you. Okay. So learning objectives, we hope that people go away understanding the stages of the menopause transition, which literally encompasses perimenopause through menopause. We want everybody to understand the signs and symptoms of both perimenopause and menopause, though many of you out there may already know the signs and symptoms. And we will look at current treatments for menopause. And I will have to say this field really has exploded over the last 20 years, and we'll talk a little bit about that as we move forward. So we have nothing to disclose. Lauren nor I work with any industry relative to this topic being discussed. So just to give you a little background here, first of all, we want to open up this talk, and I think it's really important for everybody to understand that we are talking about all individuals, and that we don't mean to generalize or assume that any one patient's experiences with perimenopause or menopause are identical or similar. And even if everybody is of the same race, ethnicity, or national backgrounds, we tell everyone that your menopause transition is unique to you. And there's been a lot more research in women in general when it comes to menopause, but also expanding, to all different cultures and races and ethnicities. And so again, we're talking about the general population and not individuals of all races. There have been a lot of barriers to care when it comes to menopause. And again, I think about my own mother and grandmother. There's a stigma attached to menopause in many different cultures all over the world. And so, people still whisper about it, and they're very afraid to talk about it. Also, the Women's Health Initiative, which many of you may be familiar with, was a study that was released in 2001. And though it was well-meaning and sought to examine whether hormone replacement therapy was really good for women's hearts, what it came away with was that, oh my gosh, all hormone therapy is horrible. And so what happened was women stopped using hormone therapy, physicians or clinicians stopped prescribing it, and then we've had this real gap in time. So there's medical mistrust, and we understand that. Also, a lot of people feel shame in some of their symptoms and are not able to discuss it. And so we hope that in our offices that we're able to, bring about the comfort level so that people can discuss it. And then I think there's a real lack of relationship that people have with their OBGYN in discussing sensitive topics. And I think that's just because people on both sides don't understand menopause, and a lot of clinicians are hesitant about prescribing hormone therapy or even talking about the options because of the Women's Health Initiative. Next slide. So let's go through a few menopause basics so that we can just lay the foundation here. So Menopause, as we've talked about, is a natural life event that every woman experiences. And we define it by looking in the rearview mirror, actually. It's 12 consecutive months without a period. And so when you look back after 12 months, that was the final menstrual period. And now, after 12 months without a menstrual period, you are in menopause. We cannot predict it. We can sort of, evaluate what went on with your mother, your aunt, your grandmother, your sister, because you might follow in their footsteps with regard to the age and symptoms. But there are no blood tests that actually predict when you're going to stop your period. The average age in the United States is 51 to 52, with a range between 40 and 58. And at the recent menopause meeting, they were even extending it to 60 years of age. And we're seeing women continue with their periods well into their mid-50s. Smoking and genetics may also influence the timing of your natural menopause. As we talked about with genetics, you might follow your mom's footsteps, so you can ask her. You can also know that smoking causes earlier menopause or premature menopause in some cases. Now, on the other hand, the age at your first period or using birth control pills or fertility medications in the past, these factors are not known to be causal factors. So just basics to keep in mind. Next slide. There really are two main stages in this transition. To the left, which you don't see, is the reproductive age. And then we have perimenopause, menopause, and then there's postmenopause, which is after the year without a period. Perimenopause has received a lot more attention lately, and it should have a lot of respect because it's hitting people in their mid to late 40s. And because we haven't talked about it, because we haven't understood it, we haven't talked about it. And so people don't get any kind of anticipatory guidance or information before it happens. And we're all busy women, and in our 40s, a lot is happening that collides at one time. And many times we're not sure why we're getting these symptoms, and it can be very upsetting. So perimenopause is usually 46, 47 in the United States is the average age, but it can last up to 4 to 10 years before you actually stop your period. And we cannot predict from when you start the perimenopause to when you're going to go through menopause. The first sign that you're going through perimenopause is a change in your cycle. It may not be irregular bleeding, but it could just be that you had every 28 to 30 days cycles and you would bleed every 28 or 30 days, and then it's reduced to, say, 23, 24 days. It can still be consistent, but that's a change in your bleeding pattern. It can also simply mean irregular bleeding. So we tell people, if you're having bleeding every 2 weeks, if you're bleeding longer than usual, 8 to 10 days or more, or if you're having heavy periods where you're saturating a pad or tampon every hour for a full day, then you definitely need to see your clinician. You also may miss periods, and so that's absolutely part of perimenopause. The perimenopause transition on average lasts 3 to 5 years, again, can last 4 to 10 years, but usually it's 3 to 5 years. And then, as we talked about, menopause is 51 to 52 years. 95%, most women will reach their menopause or postmenopause phase by 55. Next slide. There are 4 different types of menopause. We won't go into them in depth, but just so that you're aware, most women undergo natural menopause, and this is when the ovaries stop making the eggs or the follicles that the eggs grow in, and therefore you get a decrease in your estrogen because the ovary or the eggs are not making estrogen. And so that is natural menopause. That happens on its own, and that's what we've been talking about. Early menopause is that occurs before 45, And then we have something called premature menopause, which occurs before the age of 40. You might have heard premature menopause as premature ovarian insufficiency. It used to be called premature ovarian failure, but for obvious reasons, that's not a good term to embrace. And so it was changed to premature ovarian insufficiency. You can also have induced menopause, like if somebody has had chemotherapy for cancer, the ovarian function may be lost and they go through menopause. That may be temporary or permanent. Or someone may have to have their ovaries removed, and that would be a surgical or induced menopause. Okay. So just, I don't want to overload with too much information, but just to show you on the right side of this slide, that in the figure that there are many factors that can influence the onset of early or premature menopause. And so it's not just one thing, it can be multiple, or, something that you don't even, understand. So if your periods stop, you really need to see a clinician. Next slide. Again, as we talked about, induced menopause can be the removal of your ovaries or chemotherapy or radiation damage to the ovaries, or can be medications that we use for different diseases that may unintentionally induce menopause. There are problems with premature menopause, and so this is why we want women to consult with someone who knows about the treatment of menopause, because it does increase the overall mortality. It increases diabetes, cardiovascular disease, cognitive or memory impairment. It's not great for the bones and can cause early osteoporosis. There are mood disorders, sexual dysfunction, and this probably is just the tip of the iceberg. So it is very important to consult with someone who understands how to treat this. And, using hormone therapy in this scenario, if it is not contraindicated or not, there's not an adverse problem with it, is a really great idea until you get to the natural age of menopause. Anyway, so just want to point out that there are long-term health implications, and it's a good idea to get to see a clinician. So I do want to point out that across and within cultures and ethnicities, that there are variances and there are different signs and symptoms that women will experience. Black or African American women can have longer menopause transitions, and guess what? Have more significant vasomotor symptoms, forgetfulness, and vaginal dryness. They may be prone, and we know this very significantly now, to social, systemic, and institutional stressors such as racism and discrimination. And I think that we see this very often. And so this is why we need to draw people out of all different cultures and ethnicities, because we want to make sure that we understand what they're going through so we can help. Asian women have less severe symptoms, except they do have forgetfulness. And in their culture, they negatively associate the quality of life with age. Latinx women have more frequently complain of vaginal dryness and urinary issues and increased heart rate. So again, paying attention to each individual person is very important. So I know this is very busy. The reason I, though, put it up is because it shows the stages of menopause, which we've mostly reviewed. Normal reproductive or productive life is what it says on this slide, perimenopause, menopause, and postmenopause. It also will list the most frequent symptoms that you may have along the bottom during each of those phases. And guess what? That's because of the decline in estrogen. And if you look at how the curve is decreasing at perimenopause, it really is very variable. It's not a smooth downward trend. The estrogen is up and down. And that is why the symptoms of perimenopause are up and down, is because your hormones are up and down. And so if we draw your estrogen level on one day to see if maybe it's low and you're in perimenopause, it may be low, or it may be where it was when you were in your 30s. However, if we drew that blood the next day, it might be at a different place. So that's why it's hard to draw blood to see if you are in perimenopause. Next slide. Okay, so the signs and symptoms. So I love this slide because we know that perimenopause starts with a change in your menstrual cycles. Well, then the hallmark symptom that we all have heard about are night sweats and hot flashes. And these can be extreme among all women. And usually if you've had a hot flash, you know it's like a furnace that's heating up, and then you break out in a sweat. And guess what? It occurs again within that hot flash, and then you will start cooling off and sweating. But it is intense. It is very bothersome. And for many women, it really impacts the quality of life. And there are a lot of women who will come in and say, I can't do this. I get up in a meeting and I have a hot flash and I'm red and I'm sweating and people are just looking at me. And so it's significant. And if it's dismissed, then somebody needs to seek help elsewhere, because it is a quality of life issue. But it is the hallmark of menopause, if you will. Next. We talked about the stages and the symptoms of menopause before, and just to say that each person's menopause is unique. So we have all of these symptoms. It's a potpourri, a bucket, and each woman will dip into this and have symptoms in different percentages. There's not a list of symptoms that everybody will have. And again, if you ask your mom or a sister or an aunt, they will tell you what their symptoms are, what their symptoms were going through menopause. And I think this is a nice list to look at, because some people will say, gosh, my joint pain, and I'm a runner and my joints are really bothering me. And joint pain is one of the symptoms of menopause. So there is a lot going on. And many times I think women are dismissed when they complain of some of these. Next slide. This is to drive the point home, which I think I have, that symptoms affect patients differently. And that's their physical changes, their hot flashes, their night sweats. We'll talk a little bit about vaginal symptoms, because this is something that women talk about a lot in our offices. And it's usually one of the last things they mention. And I think it's because it's embarrassing. They have, women have no idea that this is something that happens with natural menopause. Next slide. So speaking of vaginal dryness, this will be in here twice. Lauren will talk about it when she talks about treatment. But if you look at the picture on the left, this is a vaginal, the skin of the vagina, if you will. And on the left, this is in a woman who has enough estrogen to have this beautiful looking vaginal skin or epithelium. And then as the estrogen dwindles through menopause in the low estrogen state, you will see that the nice undulating curves that were there are smoothed out and very straight, and the cellular layer is very thin. And so I like this slide because it really does illustrate how the lining of the vagina, it's the vulva, and also the urinary tract become very, very thin without estrogen. And this makes the walls of the vagina very narrow. The vagina is not as elastic. The area tears very easily. It's very dry. And therefore sexual relations can be very painful. Now, you don't have to have sexual relations to feel vaginal dryness. A lot of women feel it just walking around or sitting. So we like to address this because we don't want women to be miserable, and that's what happens if it's not addressed. Next slide. Okay, so I like this because I can identify, my husband wears his winter pajamas all year long, but does say, oh, it's not hot in here. And so anyway, I'm in the menopause world, and this spoke to me, and maybe it speaks to a few of you all out there. Next slide. So I will turn this over to Lauren. And as I said, we work together and just have the best time trying to figure out how to meet women where they are and try to, provide the best care for perimenopause and menopausal women. Thank you.
Thank you so much, Dr. Rosser. I am going to pick up and off of your beautiful first part of our presentation and talk a little bit about what we can do to help mitigate some of these symptoms, because I think the main goal of menopause is there's your menopausal care where we're worrying about, your physical health, we're worrying about your cardiac health, worrying about your risk of osteoporosis, and then there's your quality of life, and that's really, really important. They actually have done studies and shown that there is a drop-off of productivity in the workforce in women in their late 40s and early 50s because of untreated menopause symptoms. So we feel very, very passionate about trying to give patients options so that we can do whatever it is to help your symptoms and help you live your best life. So we'll start out with some non-hormonal treatment options. And there's different categories of treatment. So, some patients will come in and say, I'm not feeling so great, but maybe I don't necessarily want to take any medication right now. So we can always look at diet, exercise, different ways to modify your behavior, like dressing in layers, having like cooling sheets. Some patients will carry around a little fan, yoga, Tai Chi, acupuncture, all of these different things have been shown that they can help, and they help, different women will respond to different treatments. So what works for one patient doesn't work for another, but we can always start with something non-hormonal before we even go the medication route. So we're going to talk a little bit about the Women's Health Initiative, which Dr. Rosser mentioned before. This is the largest comprehensive study we actually have on postmenopausal women. It came out in 2002, and it looked at hormonal treatments for women and treatment of menopause symptoms versus the risks of hormone therapy. So this is a study where it kind of shifted the way that we practice medicine a little bit, because they stopped the study at one point because they were finding an increase in breast cancer risk. And this is kind of a complicated chart, but what the main takeaway is, which we want to show, is that this study has been groundbreaking, because even though at the time a lot of people were very turned off from hormone therapy, and this scared a lot of clinicians, it scared a lot of patients, we actually got a lot of really good data that we've since been using in other studies, and we found that this study was looking at almost the wrong thing. We were giving women hormones much later in life. We were giving specific kinds of hormones. We were doing it more than 10 years from menopause. And now we have new information regarding the safety. So we've come a long way since this study came out, but there is a kind of a lasting effect to look at sort of risks. And some of the risks that we're seeing, if we look at this chart, is estrogen and progesterone. They were finding a little bit of an increase in cardiac disease, which now the way we use hormone therapy, we found there's actually a decreased risk of all-cause mortality, including cardiac disease. And so this sort of changed the way that we used hormone therapy, and now we use it in a way that we know is very safe. And we'll talk a little bit more about this. So this is just some more information about the WHI. It was limited to women. The youngest group of women were 50 to 59, and oftentimes we'll even start hormone therapy a little bit earlier than that, depending on your symptoms, because everything is very dependent on the individual patient. We now know from other studies that we've done that there's no hard stop age for when we need to discontinue hormone therapy for patients. We used to think 60 or 65, it's a hard stop. And now we have an open conversation with patients and we talk about risks and benefits and your quality of life. You're going to hear me say the term quality of life quite frequently because that's really a very main staple and hallmark of what we're trying to practice in menopause medicine. So this is very exciting for all of us in the menopause world. The North American Menopause Society, or NAMS, came out with a position statement this year, an updated position statement on hormone therapy and just driving home the point about the safety and the benefit to women who are using menopause hormone replacement therapy. So I'll just read this aloud. I don't like to read slides, but it's just so important. So for most healthy symptomatic women under the age of 60, within 10 years of menopause, the benefits of hormone therapy outweigh the risks. And so this is the hallmark of what we're doing. This is what the data is showing. And this is what we really like to drive home to our patients. So indications for hormone therapy. We've talked a little bit about what some of the symptoms of menopause, perimenopause are, but hormone therapy we can use predominantly for vasomotor symptoms. So that's anything including hot flashes, night sweats, anything where you're having that heat, as well as genitourinary symptoms, which are changes in your changes in the vagina, changes in pain or dryness, changes with sexual activity, as well as some urinary symptoms. And then we also can use estrogen sometimes in the prevention of bone loss, and it can be a helpful tool in patients with osteoporosis, patients with osteopenia, patients who we really want to retain that bone structure and we worry about the bone health. We can use it for several years. Our goal is symptom relief using the lowest effective dose. And the beauty of hormone therapy is there's really a huge range of what we can do. There's different doses and different methods that we can deliver the medication through pills, patches, rings, gels. And so what works for one patient, might not work for another, but we have so many different options. So here are just a high-level overview of what we can prescribe for menopause. So there are prescription therapies this can include hormones, and also there's a whole range of categories of medication that are non-hormonal, some that are FDA approved and some that are not, but that we have good data to back up their safety, and we've been using them very safely for years. One of the therapies that we will frequently use is paroxetine. It's the only FDA-approved SSRI, also known as Paxil, which is an antidepressant, and in a very, very low dose, it helps control hot flashes in women who might not be able to take hormones, and it's a really lovely choice. But we also have lots of other medicines that we can use. That's just the one that is FDA approved. But again, we have a lot of data on a lot of these medications showing their safety and efficacy. So this is the slide that Dr. Rosser had mentioned we would come back to. And I think it's really helpful to see, when we've talked about the different modalities of what's happening in the body during menopause. And we'll talk a little bit more about the genitourinary symptom of menopause, but we can use localized hormones or non-hormonal treatments for what's happening in the vagina, which is essentially the lack of estrogen is changing the tissue, causing dryness, causes narrowing, just like Dr. Rosser was saying. But estrogen, local estrogen, which is not absorbed throughout the body the same way that hormone replacement therapy is, like a pill or a patch, can work really beautifully to help patients have sex that isn't painful, or just if you're walking around with discomfort, as happens sometimes, it can help with that as well. And it can also help with some of the bladder issues certain kinds of incontinence that can happen in the menopause transition, because as this is happening in the vulvovaginal area, your urethra is right there where you urinate from, and that tissue around there also gets much thinner. So that's why many, many women will say, you know, I cough or I sneeze and I have a little bit of leakage, or I have to go to the bathroom really bad and I'll have a little leakage. And we can use these vaginal estrogen treatments to help with that, which is really wonderful. So again, just going a little bit deeper into the genitourinary syndrome of menopause, we've talked about the loss of elasticity, the shortening and narrowing of the vagina, the vaginal mucosa itself changes. There's dryness, sometimes there's soreness, and this can present differently in different women. We'll have some patients say it feels like it's burning, or we'll have some patients who come in and say, I feel like I have a UTI, or I feel like I have a yeast infection, because all of these different the infection and the genitourinary symptom of menopause can sometimes really mimic each other. So we really encourage patients to come into the office to get an exam. It's really helpful if we can do swabs and kind of rule out any kind of infection and take a look at what's happening, and make an assessment and say, you know what, I don't think this is an infection, but these symptoms, you know, that you're feeling are definitely attributed to menopause. And then we can get you on the right path to treatment so you start feeling better. So different treatments for genitourinary symptoms of menopause. So we have our hormones, we have our non-hormonal options, and then we have the vaginal and pelvic floor activity. So our hormone interventions, we have estrogen, which is probably the most common hormone that we use. We also have DHEA, which is a different kind of hormone. Again, all used vaginally, and they do make one kind of oral medication that we will use that has been known to increase the estrogen selectively in the vagina. And then for patients who either cannot use estrogen or don't want to, we have a whole range of non-hormonal options. We use moisturizers, vaginal moisturizers, which are available over the counter, hyaluronic acid suppositories, which if anybody uses hyaluronic acid on your face, it's really a wonder serum. It's very moisturizing. We have good data to tell us that it can help rebuild vaginal tissue similarly to estrogen. We can use topical lidocaine. They have a laser that we use, Mona Lisa Touch. It's not FDA approved yet, but we're getting more data on it. We're learning more about it. And then also vaginal dilators, which we will often use for patients who are engaging in sexual activity and finding it's not as comfortable as it used to be. So that really helps kind of build the muscle again and allow patients to have sex without any kind of pain or discomfort. So the risks of local estrogen therapy are much different from the risks of taking oral estrogen or using patches. And while we do know there is a very small increased risk of breast cancer, which is not the same that we used to think it was, those risks don't necessarily apply when you're dealing with a vaginal estrogen. Now, they used to say anybody who has a history of breast cancer cannot use any kind of estrogen. But now what we'll do for patients who've had estrogen sensitive cancers, we have a conversation with the patient and we like to get the blessing of your oncologist. And so just because you've had a certain kind of breast cancer does not mean you absolutely can't use estrogen. Again, every individual is different. We try to personalize our care and make sure that we reach out to the oncologist and that we're doing something that's safe and effective for you. Sometimes it can cause a little bit of vaginal irritation, breast tenderness, vaginal bleeding, headaches. Very rarely hot flashes. Most patients tolerate this very well, but again, you know, no medicine comes without any kind of side effect or risk. So, you know, we keep an eye on this and we just work with you and to see how you're doing. So the lower urinary tract and pelvic floor are also affected in menopause. We see a lot of pelvic organ prolapse, which is where the muscles are no longer holding up the organs as well as possible. So if you think of, if this is your pelvic floor and there's some laxity in the muscles, a lot of times after childbirth, everything will kind of move down a little bit. This can often happen with age. This can happen after vaginal delivery. It can happen after hysterectomy. And there's options for this. So we can recommend pelvic floor physical therapy. We can send you to your gynecologist. And a lot of times this also occurs with urinary incontinence. So this is something, or anal incontinence, constipation. And again, you know, the takeaway message is there are options. There are different treatments we can do. We have specialists, even beyond our team. There's surgery kind of on the very conservative end, and pelvic floor therapy on sort of the more minimal intervention end. So sexual health changes. In our practice, we like to bring this up with all of our patients actually. And so if you come and see one of us, we're going to explicitly ask you, you know, are you sexually active? And if so, are you having any issues, any pain? Because we think it's very important, again, for your quality of life. It's very, very normal to have changes in the menopause transition. 43% of women aged 50 to 80 in the past year were sexually active, according to a study for the Michigan Institute for Health Policy and Innovation. And so we also look to address any kind of issues with pain, issues with decreased libido, safe sex, which is definitely something to consider. I think that as we age and the risk of pregnancy is not there, sometimes we don't think as much about safe sex and STDs. They happen, it's part of our care, and it's a conversation that we have with all of our patients. All right, so well woman care. So what are we looking for? What should you be seeing when you come in for your annual exam? What are we focusing on, you know, aside from the hot flashes and aside from your bowel, bladder, vaginal health, what else should we be looking at? So well woman care, we love this slide. It's an excellent opportunity for well woman care, including screening, evaluation of health risks, and counseling. So even after patients are done with childbearing, or if they've never had a child before, we still encourage everyone, come in every year, have a conversation with us. You know, we have a little bit of a different perspective than primary care physicians. And we work in conjunction with them. We're a team. We're all part of your global healthcare team. So come see us. All right, so we look at hypertension and cardiovascular disease. This is a big focus of our practice. It's one of the passions of Dr. Rosser, cardiovascular disease in women, because as you go through the menopause transition, your cardiovascular risk increases and it becomes closer to that of men. So we want to pay very close attention to that. Screenings for cancer, colorectal cancer, breast cancer, looking at your mood, depression, anxiety, and also osteoporosis. Were you a smoker? Do you have a history of osteoporosis? Have you been on glucocorticoids for a long time? All of these things take into account when we'll start screening you for osteoporosis. So we'll end with this lovely quote from Michelle Obama: the changes, the highs and lows, and the hormonal shifts, there is power in that. And thank you so much for coming to our talk today. And we want to open up the floor for some questions if anybody would like to ask anything.
No, ladies, that was terrific. Lots of really good information. And it's interesting because I learned a lot, and especially with menopause could come joint pain. I've never heard that before. And the studies that you were talking about with the hormone replacement therapy and the breast cancer, because that's what everybody has heard of for years, right? I want to ask you a question before we open it up to everyone else. Can you talk a little about the link between memory loss and menopause? You did mention it's higher in the Asian population. Is there any other information that you could tell us?
So this is an exploding area of research, but we do know that women have this brain fog, word fog, word recall is down, and we get that as we get older. Also, the concentration is down in women. They'll come in and say, I can't concentrate. I feel like I have brain fog. Usually that will abate in 3 to 5 years, like most of the menopause symptoms, except for the vaginal dryness. But we know that we have to protect the brains of women who go through early and premature menopause. So we know that there is a link, but we don't know exactly what that is yet. There is no indication for using hormone therapy right now in women with natural menopause to protect the heart or the brain. But I will tell you, as this field has just, you know, really grown out of control almost in the last several years, we will be getting more information fast.
So folks, if you've got any questions, please feel free. You can put it in the Q&A. As we wait.
Oh, sorry. I
was
also
gonna say,
wanted
yeah.
to mention that Columbia has purchased a property that used to belong to Pepsi, and I don't know if it was the bottling company, and it's at 1111 Westchester Avenue in White Plains. It's a beautiful office park, if you will, and will be a multi-specialty care group, or set facility for Columbia providers for providing care to people in Westchester. So
Thank you. I'm so glad you said that. I know you texted it or you emailed it, and I wanted to mention it. I'm so glad. Thank you.
So we're excited about expanding our menopause care to Westchester at some point.
Dr. Rosser, are there some common questions that people have been asking you that you may want to get into? And then I do have somebody who does have a question.
Okay, so there is one that Lauren and I hear about quite a bit. And women come in, they're very distressed about the weight. And it is distressing. Recent research, though, shows that menopause itself does not induce weight gain or, issues with increased weight as far as the number. What does happen, though, is that there's a redistribution of body composition, meaning there's a redistribution of fat in the body, and it goes from all the other tissues to your belly and your hips. And so women will frequently say, I have this tire around my belly. I haven't changed my eating. I haven't changed anything. And if we all kind of delve into it ourselves personally and do some soul searching, this is a point in life where women are more sedentary because we're doing a lot more that involves, our sedentary jobs after the pandemic. And we have just changes in our lifestyle. We have, children, we have parents, we don't have time to exercise or maybe eat properly or at the right times. And so what you find in exploring people's diets is maybe they eat more at the end of the day or in the evening when they're at home. Maybe there's more than the one glass of wine, and there's not as much exercise as our cardiology colleagues would like women to have. Recent research has shown that actual weightlifting or weight training changes the body and can actually help with the abdominal issue. But starting hormone therapy is not going to significantly decrease the weight. And so I don't like to say you have to embrace this new part, because people don't like that. It's not satisfying, but it's really about optimizing our lifestyle. So I don't have a magic, there's no magic bullet.
There's no magic bullet for the happy, happy, joy, joy weight redistribution.
I know. So Lauren, do you have anything to add?
No, I think just driving your 2 points home about weightlifting, our cardiology colleagues say 30 minutes a day, 5 days a week of moderate intensity exercise. And that can just look like walking. You don't need to join a gym. You don't need to get a Peloton, just walking, but doing some weight training 2 to 3 days a week, even with light weights, can really help. It's great for your bone health as well.
I hear you. Okay, we do have a question. This attendee has sensitivity to vaginal hormone cream and tablets. Can increasing the dosage of estradiol patch be a solution?
Do you want to take this, Dr. Rosser?
No, why don't you go ahead and I'll chime in.
All right. So Unfortunately, for the vulvovaginal symptoms, usually systemic hormone therapy is not the first line that we use. It would be something with the estradiol, the tablets, the patches, or the tablets or the creams. But there are different formulations that we can use. So if one's not working for you, we can explore another one. And if for some reason, we just can't find one that works, we can consider the DHEA. In certain cases, in some patients that have very sensitive skin, through pharmacies, compounding pharmacies that we trust very much, sometimes we can get a compounded estradiol. And if there's some sort of skin allergy, we can get something made without, let's say, propylene glycol is a major additive that many people have sensitivities to. So those can be solutions. And then there's also the non-hormonal option. We can try hyaluronic acid if that's not working. So, don't fret. There's a lot of other options.
Okay. Before I talk about this next question, I want to tell all the attendees, at the very end, there'll be a slide and you'll see Lauren and Dr. Rosser's information up on the slide. And there is an office in the city. Also, I'll follow this up sometime next week. And I'll send an email out and you'll get that information again. So let me read you the next question. Postmenopausal, started my period at age 9 and menopause at 38. I'm 67. My past gyno really did not believe in hormone therapy. Several years ago, I got vaginal dryness extreme. Got prescribed estradiol vaginal cream 0.01% twice a week. I have flashes at night, turned my back and neck, not during the day, started getting symptoms post age 50, weight, etc., and I was working out. I live in Manhattan and would like a consultation. Is there a Manhattan office?
So, yeah, so both Lauren and I practice in our two Midtown offices, 51 West 51st Street, which is right across the street from Rockefeller Center and Radio City. And then the other office is at 5 Columbus Circle, which is in the same building as Nordstrom's, which I love to say. And so we would be so happy to see you. I'm sorry that someone did not believe in hormone therapy. The local vaginal cream, if all people have left is the vaginal dryness and all the other symptoms have either gone away or you haven't had other symptoms, we recommend local vaginal estrogen and not the systemic hormone therapy that we use for hot flashes, etc. And so if you're experiencing those symptoms now, I usually advise a really great, thorough primary care for a good physical, and then we can work with you also on the other symptoms. So I'm sorry that you've been uncomfortable, and I'm sorry that that was not an option for you, but we can help. There was something I wanted to go back to, if I have 1 second. The vaginal cream and tablets, Lauren is right. We can get the estrogen compounded, and there's some really great compounding pharmacies. You have to be careful with compounded hormones because they're not approved by the FDA. We don't know how much is in them. And so, but by going to a reputable compounding pharmacy, and there's a couple in Westchester that we recommend, you can have it measured perfectly so we know what you're getting. And so having a different base is really good. We also have a vaginal estrogen ring called S-string or E-string. And for people that have reactions to the tablet or the cream, that works. And then the Mona Lisa laser treatment, we're getting more information on, but that seems to be working for many women as well.
We do have time for one more question, folks. Anybody have a question? No? Okay, well, I want to thank you all for joining us this evening. Thank you, Lauren. Thank you, Dr. Rosser. Very great information. Folks, we will be posting this onto our website in about a week or two. Again, look for the follow-up email. It'll have the information how to contact our speakers. And if you'd like to contact the Kensington, we are here Please feel free to call us at 914-390-0080. Have a good night, everybody. Take care.
Bye. Take care. Thank you.